Good morning. Welcome to the first event of this year of Feline. We have a meeting with the expert, with Dr. Mike Irwig. I'm Dr. Cristina Alonso. I'm an internist and endocrinologist. I'm part of the board of directors of Feline, former president of the Uruguayan Federation of Endocrinology, and I work with transgender patients in the British hospitals. This is the first of several activities programmed for this year. We have foreseen other 4 meetings with the expert, and such as last year, activities for residents and specialists. In all cases, with very distinguished professionals. Let's see some practical aspects of the session. We will keep our cameras and microphones off. We will be receiving questions you sent beforehand during your registration, but we invite you to use the Zoom chat to write any questions you might have. You can also speak up at the end of the conference using the raise hand tool. We will have interpretation services to English. You have to click on the globe you see below. The certification of attendance will be given to those that remain connected for a minimum of 40 minutes. In addition, we will have the recording available. As mentioned, today we have a top of the line speaker. Dr. Sierra will introduce him. Dr. Sierra is an internist and endocrinologist. She's Colombian, member of a multidisciplinary group for managing patients with gender dysphoria and gender incongruence of the San Jose Hospital in Bogota. She's a member of the Colombian Association of Endocrinology, president of the Central Chapter. We'll yield the floor to Ariana so she introduces Dr. Irwig. Good morning, Dr. Cristina. Thank you very much. For me, it's an honor. I would like to thank Feline for the invitation. I have the pleasure of introducing a marvelous speaker, Dr. Michael Irwig, who's an adult endocrinologist. He's a director of transgender medicine in the medical center, Beth, and he's associate professor of medicine in the School of Medicine of the University of Harvard. He received his Bachelor of Arts in the University of Vanderbilt and with a recognition of summa cum laude. He graduated from Cornell University with honors. He completed his residency in internal medicine in the University of Virginia and his scholarship of endocrinology in the University of Washington, NCR. He has provided endocrine care to over 400 patients of different genders and investigates the effects of gender affirmation hormonal therapy. Other points of his research interests are the effects, the persistent effect, both sexual and non-sexual in men on the use of finasteride. And he has over 40 publications in different journals, peer-reviewed such as Lancet and the Urology Review, and the results of his research have appeared in many publications and dissemination media, both national as well as international, such as NBC, ABC World News, CBS, CNN Doctors. Currently, he is a member of the Professional World Association for Transgender Health, and he is co-author of 2 chapters of the standards of care of the guidelines of this association. He has presented over 150 conferences in different hospitals and schools of medicine and conferences in different continents regarding transgender health and masculine hypogonadism. He's associate editor of the Andrology Sexual Medicine Review Journal, member of the board of directors of the Endocrine Alliance of New England, and in his free time, he enjoys traveling, nature, and animals. We welcome Dr. Michael. Thank you very much. Yes, good morning and greetings from Boston. Welcome to this session. It's a pleasure to participate in this event of the Latin American Federation of Endocrinology. Thank you. I would like to thank Dr. Pilar de la Peña, Ariana Sierra, and Cristina Bolson. The organization of the event has been fantastic. I don't receive any funds from the pharmaceutical industry. I can say whatever I wish on any of the drugs. So let's get started with an interactive question. For transgender adults, they need to have a therapist or a psychiatrist while they are taking hormones. Is it true or false? You can respond via the chat. Okay, there is a mix of answers. The correct answer is false. It really depends on the patient. If the patient has non-controlled depression, it would be a good idea. But if the transgender patient, as such, does not suffer any mental illness. These are some questions I use with my trans patients in their first appointment. For example, tell me about your childhood. When did you first realize you were trans or non-binary? How was your puberty? Who knows you're trans? Does your family support you? Have you been under the care of therapists for gender dysphoria? How is your mood? Do you have anxiety or depression? Have you attempted suicide? What are your treatment goals with hormones? Recognizing the social determinants of health of trans people. Discrimination occurs in many places. For example, in this questionnaire from the United States, 34% did, or 24% did not receive the same treatment or hospital. 25% felt harassed, and 2% were physically assaulted. It is not surprising that there are disparities among the trans and cisgender populations. This study is called the Behavioral Risk Factor Surveillance System. These are data collected from several states in the United States. Compared to the cisgender population, transgender people have a lower likelihood of having a high school education, greater probability of living in poverty, less probabilities of holding an employment or of having a health insurance, and more possibilities of being overweight or obese or other health issues. In the United States, approximately 5% of patients in gender clinics have autism. People with gender diversity have 5 more times possibility of suffering autism, a 5-fold probability. Hormone regimes. Which is an appropriate hormone regime for a trans woman? Is it ethinyl estradiol plus spironolactone, or is it oral estradiol and progesterone? Is it oral estradiol and spironolactone? Is it transdermal estradiol and finasteride, or none? And once again, you can answer in the chat. Okay, let's see. There's a mix of B, C, D. Okay, B, C, and D. Okay, the correct answer is C, and we will review why. Okay, estrogens. There are several options of estrogens for trans women. Historically, the most common formulation has been oral estradiol, which is cheap, but there are risks of venous thromboembolism with this formulation. To take sublingual estradiol probably entails less risk because it's not metabolized by the liver. The patch has the lowest risk, and intramuscular estrogen is very effective, but it's easy to abuse of it. Avoid ethinyl estradiol, which is has a higher risk of venous thromboembolism, and avoid oral conjugated estrogen because you can't measure the level of estrogen in blood. However, in many countries, the price of estrogen determines what people use. To lower testosterone, we also have several options. In the United States, we use spironolactone. In some countries, it's more common to use cyproterone acetate, and you can use a GnRH agonist, the gonadotropic release hormone. It's very expensive and not very much used in adults. This graph compares the same dose of oral and sublingual estradiol. On the y-axis, we have the concentration of estrogen. A couple of hours after taking the pill, the level of estrogen is higher with a sublingual formulation in red than in the oral formulation in orange. That's why you always need to ask the patient, when was the last time you took your pill? There's several testosterone options for trans men. Historically, the most common formulation has been intramuscular testosterone, which is cheap. The differences between the other formulations include the route, frequency, and price. For example, gel and patches are applied daily and are more expensive. Most of my patients are using subcutaneous injections. The use of progesterone in trans feminine individuals is not recommended. There are no studies that assess the safety of progesterone in trans women. However, some trans women believe that progesterone increases the increase in the size of their breasts and improves their mood. We really need results of a controlled randomized clinical trial for that. But if I do give progesterone to trans patients if they are aware of the fact that we do not know the benefits or risks of taking it. Another controversy is the use of finasteride in trans people. Normally, part of the testosterone is converted in dihydrotestosterone or DHT. And trans women that take estrogens and anti-androgen normally have lower concentrations of testosterone and DHT. That's why I don't see any additional benefit with finasteride. Such as the case of progesterone, there are no trials that assess safety or efficacy of finasteride in trans patients. In fact, a trans woman that has baldness can have hair growth by simply using estrogens and spironolactone. Look at the change after 6 months with this treatment. The use of finasteride can be different with trans men. This Spanish trial had 10 trans men. 70% of them had relatives with baldness. Baldness took a mean of 3 years to develop. Baldness improved in most patients with finasteride. However, there are no trials assessing safety of 5-alpha reductase inhibitors in trans men. It is possible that they avoid masculinization. Educating patients on the effects of hormones and monitoring. The most desired effects of estrogen are less gender dysphoria, less depression, less anxiety, breast growth, change in body composition, more fat mass and less muscle mass. Other effects are softer skin, less erections, a smaller prostate gland, less sperm, less sexual drive, lower hemoglobin, and changes in cholesterol, such as an increase in triglycerides. The desirable testosterone effects are less gender dysphoria, less depression, less anxiety, more face and body hair, a cessation of menstruation, lower voice tone, and more muscle mass. Other effects include a lower risk of breast cancer, growth in the clitoris, an increase in sexual drive, higher blood pressure, higher hemoglobin, and changes in cholesterol, such as lower HDL cholesterol, which is a good cholesterol. Unfortunately, for many trans women, the breast growth is few. In this study with 197 trans women that received estrogens for 1 year, less than 10% achieved an A-size bra cup. So a lack of appropriate growth makes some trans women abuse estrogen as well as having breast augmentation surgery. Okay, how do we monitor patients that take hormones? We see their testosterone and estrogen levels. These figures are based on experts' opinions. I also measure cholesterol or potassium since they're taking spironolactone and hemoglobin in trans men. Prolactin can raise a bit with estrogens, but it's not clinically relevant. Liver enzymes can also increase a bit, but they should not be measured or need not be measured. What is the target testosterone level for trans men that's taking testosterone? The breadth of reference is broad, between 250 up to 950 nanograms per deciliter. We need to consider the average of total testosterone in a cisgender man that's 40 years old, which is around 475. To educate patients on hormone therapy on fertility. Trans men can become pregnant if their organs are present. For example, Thomas Beatty received the sperm from a donor, and pregnancy is possible after suspending treatment with testosterone. Testosterone should not be used as a contraceptive. If a trans man uses testosterone, becomes pregnant, he should stop it because it's an X category medication that can cause fetal harm. For trans women, a high dose of estrogen for a prolonged period of time can cause testicular atrophy and infertility. For someone that desires to have a biological son, a strategy would be cryopreservation of sperm. However, the fertility of trans women is variable. In this German study, a group stopped taking their hormones 6 weeks before an orchiectomy. This group, represented in the black bar, almost half, had complete spermatogenesis. Recognizing and managing cardiovascular risk. My team examined the effect of hormone therapy on blood pressure in more than 450 transgender patients in Washington, D.C. In 2 to 4 months after beginning hormone therapy, their blood pressure, the mean systolic blood pressure, was lower in trans women and higher in trans men. Before beginning hormone therapy, 39% of trans women had hypertension, stage 1, and 19% stage 2. For trans men, it was 3% stage 1 and 9% stage 2. My team also examined the effects of hormone therapy on body weight. On the right side, we have change in body mass index in time. After beginning hormone therapy, trans men had a weight gain, and that didn't happen in trans women. Prevalence of obesity was higher in trans men than in trans women. Before beginning the hormone therapy, the prevalence was 25% for trans women and 39% for trans men. At the end of the trial, over half had a BMI above 30. Should I order a PSA or a mammogram for my trans patient? Prostate cancer is very uncommon in trans women. In this article of 2017, there were only 10 cases reported in the literature. Half of the cases began hormone therapy after the age of 40. It is possible that they had cancer before they started with hormone therapy. There is no evidence that obtaining a PSA level in trans women will prevent a death from prostate cancer. Breast cancer is very uncommon in trans people. This is a trial from the Netherlands. Bear in mind that very few people were above the age of 65, less than 1%. And the rate of breast cancer for 100,000 persons a year was 155 for cisgender women, 4.1 for transgender women, and 5.9 for transgender men. There was one case of breast cancer in almost 800 trans men and one or two cases in 2,300 trans women. Therefore, the decision of sending a PSA or a mammogram should be individualized. Making your patient feel welcome and respected. It is important that everyone in the clinic or hospital use a correct pronoun for the patient. Patients can feel uncomfortable with an incorrect pronoun that contributes to gender dysphoria. Some forms are not inclusive. For example, men, women, single, married, divorced. It's best to use the assigned gender at birth, masculine, feminine, intersex, for gender identity, man, woman, trans female, trans male, non-binary, other, or prefer not to say. For pronoun, it can be he, she, they, other. Sexual orientation, gay, straight, bisexual, asexual, or prefer not to say. And relationship, single or partnered. The left flag is a transgender flag. Put a flag on your clinic or hospital. The message means you're welcome. We respect all patients, regardless of their identity or their gender identity. Some years ago, I applied a questionnaire to 80 endocrinologists in Washington, D.C., and the newer generation of physicians are learning about caring for this population. They are receiving this wisdom in their residencies and in their fellowship. Most of them want to offer care for trans patients. For example, almost 80% wanted to offer care or were willing to treat trans patients. However, many endocrinologists have not had that many experiences with trans patients. More than half in this study had no trans patients in their clinic at all. Another question has to do with the competency in caring for trans patients, and 33 responded they know nothing about it. Only 11% responded they have a very high competency in caring for these patients. And another question was, to talk about sexual orientation and gender identity, how comfortable they felt, and only 20% feels very comfortable speaking about sexual orientation and gender identity. And trust. Trust is the foundation of a relationship between a physician and a patient. We need to feel comfortable discussing gender identity. That is much more important for trans patients because oftentimes they've had bad experiences in our system, in our clinics, and in hospitals. So in conclusion, recognize social determinants of health in trans populations, know which hormone formulation are preferred for testosterone. The testosterone dose that is used for trans men is normally half of the dose that is used for a cisgender man that has masculine hypogonadism. And for trans women, the doses we use are higher than the doses we use in cisgender women. Counsel patients on the effects of hormones and monitoring when these effects will be noticed. And there's a lot of variability here. Not all patients will notice all the changes. For example, it is possible that a person gets acne or not, or body hair or not. Educate patients on the effects of hormone infertility. Many of us don't know about this, but especially with trans women, when they stop using testosterone, oftentimes they can become pregnant. But in my practice, I've had few patients that desire to have a biological child after starting their hormone therapy. Recognize and manage cardiovascular risk, and recognize that there is no evidence for certain cancer detection tests. We don't have evidence of this in this population. So you can ask for certain screening tests, but they would have to be individualized. And it will depend on the patient's age, when they started hormone therapy, duration of the hormone therapy, family history, and others. And make our patients feel welcomed and respected. For more information, I would recommend the Standard of Care's version 8 of the World Federation of Transgender Health. This federation will have a conference in Portugal in September, and there's also a guideline from the Endocrinology Society, and this guideline has the hormones and the dose, and it's shorter than the Standard of Cares in version 8. Thank you for your attention, and I will be very happy to listen to any questions you might have. Thank you. Very well. Thank you, Michael, for your presentation. Spectacular, as we're all used to hear you. We'll have a space for a Q&A. Some were sent beforehand, but first, if there are any comments or questions from the Zoom chat. If anybody would like to use the raise hand tool, they're welcome to. First question. Dr. Ocampo from Uruguay. In our country, we have cyproterone in addition to spironolactone. A colleague is asking if you have cyproterone, which of the two would you prefer and at what dose? knowing that there are reports of meningiomas with ciproterol, and we are using lower doses. And then there is a B part of the question I would like to ask afterwards. Good question. We don't have access to these drugs in the US, which is cyproterone acetate, but there are some cases of meningioma. And that's why I think that this drug is being used less and less in countries where this drug is being used. Correct. And to complement, so estradiol valorate, when you reach a dose of 6 milligrams per day and your estradiol targets in blood are not reached, what would be the strategy? Well, there is a portion of patients that didn't reach an appropriate estradiol level with oral estradiol or with a patch. And we don't know why, but in some of my patients, I continue increasing the dose, but their estrogen does not reach the target figure. In these cases, and they're few, they're less than 5%. I switch the formulation to injected estrogen, and that always works very well. But I don't like to use injections because it's very easy to abuse them, and there's not that much research with these formulations, and we also have very high and low levels that change with injections. Thank you, Dr. Michael. Excellent conference. Very, very thorough. There's an interesting question. It's something you mentioned in your presentation, the role of progestins in gender affirmation therapy in trans women, but expanding the topic in the case we decide to use it, at what dose would it be and for how long? With progesterone, there is controversy because there's several of them. And in the Women's Health Initiative trial, the message of this large trial is that hormones are bad for women. And after this study, the use of estrogens and progesterone was lower in cisgender women. However, some progesterones are more androgen and others less androgen. The progesterone I recommend is micronized progesterone with a dose of 100 milligrams each night. And it's as a trial for the patient. You tell them, take this progesterone from 3 to 6 months. And if there are no positive changes, I recommend the patient to stop taking that drug. But if the patient says, well, I'm feeling a lot better in my life, I'm sleeping better, my mood is better, or my breasts are growing, they can continue. But I don't have many patients that use this drug, but there are many questions on the use of progesterone in trans women. Dr. Rodriguez from Paraguay, and Hernandez from Chile, and Jojoa from Colombia ask about the use of hormone in elderly patients, how to do the transition. We don't have many studies in transgender people that are elderly, and there is like a void there. We don't know what the effects of using hormones for 20, 30, or 40 years are, a strategy would be to reduce the dose slightly to be less aggressive. For example, in a trans woman, the levels of estrogen that I aspire to are lower than for a transgender woman that's younger. In a 20-year-old transgender woman, they're usually very concerned about the size of their breast, but for a 60-year-old woman, she's not thinking the same. But I would recommend to continue with the use of estrogen. If a trans woman has had an orchiectomy and decides not to use a hormone, would have bad effects on their bones, for example, there will be an increased risk for osteoporosis. So I would recommend a dose of estrogen, but perhaps to reduce the dose. And in a trans woman that is above the age of 60, I would recommend them to switch to a patch, for example. Perfect. Thank you, doctor. Dr. Natalia is asking, she's from Fusco, Uruguay. In transgender men, what contraceptive method would you advise them to use? There's several options. The first question would be to see what is a partner of a trans person. It can be a cisgender woman or a cisgender man, a trans woman, a trans man. So we need to see what their general practices are, their sexual practices. Oftentimes, for many trans men, their attraction is towards women, cisgender women. And in this case, it's not necessary to use a contraceptive method, but if their partner has sperm, they would have to discuss this use. There are always contraceptive pills available, but oftentimes patients don't want that because they have estrogen. There are other methods that are long-term, that are implants, a copper IUD, or hormone. And in this case, I recommend discussing with their gynecologist all the options that are available to avoid a pregnancy. I'm reading in the chat too. I'll incorporate questions in the chat. Age of beginning hormone therapy after the person used blockers, oral blockers. I am an adult endocrinologist, so I only see patients starting the age of 18. But if you see adolescents, you can use treatment for puberty cessation. You shouldn't start with that before stage 2 of Tanner. They must have already entered puberty. In the US, this is far more complicated because this has to do with minors, and that has to be done in a center that has experts, where there is also a psychologist, a pediatric endocrinologist, the parents of the teenager, and the teenager. And the role of mental health is very important. It's far more important for adolescents because some of them don't have the same maturity than adults. But the strategy would be to offer a blocker in stage 2 so that adolescents don't have the secondary characteristics that could be harmful or that can cause gender dysphoria. For example, in a female adolescent, she doesn't want to have an Adam's apple, and she doesn't want to have a low voice. And in a male adolescent, he doesn't want to have a breast growth, for example. But these blockers, it's typical to use them just for a couple of years and then switch to testosterone or estrogen. Very well. Thank you, doctor. Another question from Dr. Marindita from Uruguay. What impact does affirmative hormone therapy have in bone health of transgender patients? I didn't get the question. In the what health? In the bone health. In bone health. Okay. If patients are receiving hormone therapy, normally that is bone protective. If they're receiving testosterone or estrogen, that is protective as well. But we always have to think in patients that, for instance, don't visit their doctor for years. I've had patients that have undergone surgeries or chiectomy, for instance, or patients that don't have their ovaries, and if they're not taking hormones or if they're non-binary and that they don't think it's important to take any hormones, it is important to measure their bone mass density to see if they are beginning to present osteoporosis, and also discuss the effects of hypogonadism in patients that don't use hormone. But testosterone turns into estrogen. That's why it's also protective. To make this more dynamic, we will yield the floor to Dr. Teran. Good morning.
Buenos días.
Good
Buenos
morning.
días.
I'm Dr. Jose Teran Davila. I'm a gynecologist and molecular biologist in human reproduction, graduated from the National Institute of Sciences Salvador Subirán in Mexico City. Yes, thank you. And do you have any suggestion regarding contraception? That was the last question. Anything you would recommend for trans men? Dr. Irwig, I'm very happy to listen to your conference as well as the organizing group, but my message is very clear and precise. When we have a trans patient, the first thing we should investigate is if there is no enzymatic, genetic, or molecular disorder that is causing this problem. Because oftentimes we have patients, trans women, that have always had women as partners, but when we study them, we discover they have a 21 hydroxylate blockage, and that's the reason why their sexual inclination is distorted. In these patients, after we give them treatment to correct the production of cortisol, these patients once again have a sexual interest in male. And that is very important because this can hide a disorder that can be dangerous for their lives. Since the cisgender population and the transgender population They can suffer the same disorders. For instance, being intersex or congenital adrenal hyperplasia, and there are other options as well. So you always need to consider the development, their puberty, their physical examination to know if there's something else. But in the vast majority of trans people, they don't have any genetic disorder or an enzymatic disease, for example. But we would always need to consider it and not only see things in a simplistic manner.
Muy bien.
I think
Yo
that
pienso que sí deben tener
they
muchos
must have
trastornos
physical or enzymatic
enzimáticos.
disorders,
Lo que pasa es
but
que no
they
son
have not been
suficientemente
studied enough
estudiados porque
because there
no
are
somos
not that
muchos
many
expertos
experts in
como en
molecular
biología molecular de la
biology of
reproducción
human
humana.
reproduction, and
Puede
it could
pasar
be overlooked.
desapercibido.
Very well. Thank you, Dr.
Muchas gracias.
Avila.
Le
We now
damos la
yield the floor
palabra
to
al
Dr.
doctor
Duque,
Duque,
who
que se
raised his
levanta la
hand.
mano.
Good morning, Dr. Irving. Congratulations. I hope to meet you in Cartagena. Congratulations to the coordinators. And could you please share with us something more about the cardiovascular risk of testosterone in trans women? Yes, cardiovascular risk is complicated because we don't know a lot about it. When we start with hormones, we're usually giving hormones to people that are 20, 30 years old. In this population, it's not very common to have a heart attack or a stroke, and we don't know what will happen when they are 50 or 60 or 70 years old. That's why my strategy is to use the lowest dose for making these changes and for reducing risks. In transgender women, there is a risk of stroke, and that has to do with the use of estrogen. And we don't know if there's a formulation that's better than another one. It is possible, but there's not much research with that. With regard to lipids, estrogen increases HDL cholesterol, which is a good cholesterol, and oftentimes lowers systolic blood pressure, and that's good for trans women. But for trans men, they can have a higher systolic blood pressure, and they can also have changes that are not very favorable with their lipid profile. For example, a good cholesterol that is lowered with HDL. They can have both transgender men and trans women can have an increase in their triglycerides, estrogen, or testosterone. That's why it is important to take these measures in their patients with weight, for example. If the patient is overweight or obese, it's a good opportunity for discussing the opportunity to ask the patient if he's exercising, if he's going to the gym, what type of diet they have. It would be good to have a consultation with a nutritionist, measure blood pressure. But I have noted in some trans men that their body weight has increased around 40 pounds in a couple of years. And that affects a lot, not in everyone. There's a lot of variability, but hormones can contribute And they also contribute to fat mass because there are several types. There's visceral fat that's around the organs, and that is a fat that's not good for health, and subcutaneous fat that's under the skin that does not have the same risk. That's why I try to use a dose of testosterone that is not that high in trans men. I normally try to keep their blood levels more or less in average of 400 nanograms per deciliter. Because if the dose is higher, there is no evidence that they will receive better effects. There's more risk for acne, alopecia, and cardiovascular risk. Very well, thank you. We have Dr. Catherine that raised her hand. Oh, the floor is yours. Thank you for your lecture. Excellent. And I have a question regarding patients that have a desire to have a surgery like a mastectomy. Would it be recommendable to do the surgery after a time of using the testosterone, or can this be done before beginning the therapy? Thank you very much. In the past, there was a rule in the United States that trans patients have to take hormones for 1 year before a surgery, for example. But that has changed, especially because we have non-binary patients, and there are non-binary people that want a mastectomy, but they don't want to take testosterone. So it's not necessary to use hormones. And in several studies, it's 70% of trans people that choose to use hormones, and there's a 30% that decide not to use any hormones and only transition physically with the clothes they wear, etc. A good question, but the most desired surgery for trans men is a mastectomy. And it's very common for this population to desire this surgery. Ariana, would you like to ask a question? Yes, thank you. A question from Dr. Teresa Torre from Mexico. What legal aspects exist in treating patients with that are transgender? Legal aspects. Well, legal aspects. It depends on the country. I know that in many countries there are laws where a transgender person has to remove their reproductive organs to change their gender identity in a document, for example, in their passport. And in many countries, they have these laws that are inhumane, that they force people to have a surgery to remove their ovaries or their uterus or their testes in order to change their
por la parte de ciertos políticos sobre el cuidado del paciente adolescente. Y en muchos estados, en los Estados Unidos, hay algunos políticos que han prohibido este tratamiento en sus estados. Y eso es muy triste para adolescentes porque no pueden ver a psicólogos, no pueden recibir bloqueadores. A veces tienen que viajar 10 o 20 horas para ir a otro estado para recibir este cuidado. Y para adolescentes y gente joven transgénero que no pueden tener acceso a estos servicios, a las hormonas, esto contribuye mucho a la disforia de género, a la depresión, a la ansiedad y a intentos de suicidio. Por eso es muy importante que todos nosotros hablamos con nuestras familias y con los amigos
And
con los
friends and
líderes,
politicians.
porque los que saben mejor para un adolescente, creo que el
I think that
adolescente, los
adolescents,
padres, creo
parents, and
que
doctors
saben
know
mucho
a lot
mejor
better
cuál es lo
what is
bueno para
best
los
for
adolescentes
adolescents
que
than a
viven
politician that knows
y no
nothing
saben nada
about the
de
situation.
la situación.
The situation adolescents are experiencing.
Muchísimas
This
gracias.
is the
Tenemos una
final
última
question.
pregunta, lástima
Unfortunately,
que
we don't
tenemos
have
poquito tiempo,
much time left,
pero me
but
gustaría
I
preguntarle,
wanted to
dado que no
ask you,
tenemos
since
aún
we don't have any
alguna
guidelines
guía
for
de manejo de pacientes
managing
transgénero no binarios,
non-binary people,
¿cómo se está
how
manejando?
you are managing this.
Sí, este
This
grupo ha
group
crecido
has grown
mucho
a lot.
en los últimos 5 años.
They're a
¿Por
bit
qué?
different.
Porque muchas veces personas
Sometimes
no quieren
non-binary
no
people
quieren
don't want
tomar
to take
hormonas
hormones.
o a veces ellos vienen a mi clínica y dicen, bueno, yo
They
quiero
say, I want this and this effect of the
recibir
hormone,
testosterona, pero no
but not
puedo
this
recibir
other
este
effect.
efecto y el otro efecto.
And we need
Y
to
hay que educar
educate
a los
patients
pacientes
that it
de
is
cómo
not
es posible
possible to
elegir cuáles son
choose
los
the
efectos
effects they will have of the
van a tener la
testosterone
testosterona
or of
o
estrogen.
el estrógeno. Y muchas veces
This
depende
depends
de la
on the
persona, de
person,
la
of the
genética, de la
dose,
dosis, de la duración. Y
and
también
there's
hay
also a
mucha
lot of
discriminación
discrimination against
con los
non-binary
no
people.
binarios, porque algunas
Because some people
personas
think that,
creen que
well,
como
they're
son
trans,
transgénero,
but they're just
son
confused, and
confundidos y no saben qué quieren. Pero
there are
igualmente
people
hay
that
personas
say,
que dicen, bueno, yo
I'm
puedo
not a man,
ser
I'm not a woman,
mujer, yo puedo
I'm a
hacer
mix.
una mezcla, yo
I
puedo
have a
tener
male
una parte
part, I have a
masculina
female
y una
part,
parte femenina. O también
and there are other people that
gente
say,
que
well,
dice,
I'm not a
bueno, yo
man
no soy hombre,
and I'm
pero
not a
yo
woman
también no
either.
soy una
I'm
mujer, yo soy uno y
neither.
uno.
I can be
Puedo ser
asexual
asexual o,
or
transgénero.
agender.
Y yo
I
soy
am the way I
quien
am,
soy
and
y
I
no
don't want
quiero
to have any
un género,
title or label.
un label de mi género. Pero sí
But
está
it's
creciendo mucho
growing.
más
This population
esta
is growing
población.
more.
Y
And the
en
new
las
generations in the
personas en
United
los Estados
States,
Unidos, en las personas que tienen
people that are less than
menos de 20
20,
años, creo
I
que
think it's 2
2 a
to 9%
9%
identify
se
themselves as
identifican como
transgender
transgénero
or
o no
non-binary.
binario.
Well, we have many other
Tenemos muchas
questions.
preguntas, lamentablemente el
Unfortunately,
tiempo se
time
nos
is a
agotó.
tyrant
Vamos
and
a
we
tener
have to
que
close our
ir cerrando
event.
el evento. Me
We would
gustaría
like
agradecerle
to
muy
give an infinite
públicamente
thanks
a
for
Irwig por
Dr.
su
Irwin for his
presencia
presence
en
in
este
this
evento.
event. Of course, Dr.
Por supuesto a la
Sierra
doctora
for sharing
Sierra
the
por la
coordination,
coordinación y a
Felaen
Felaen
for
por la
organizing this
organización de la
activity.
actividad.
We hope to see you
Y los
next
esperamos para la
time,
próxima, que
and we will
seguramente será
share
en
the
breve
date with
ustedes.
you
Así que los invitamos a
soon.
prender sus
Please
cámaras,
turn on your
a
cameras
saludarnos
to
y darles las gracias, sí, a Michael
be able
por su
to greet us
presencia
all
y
and to
acompañarnos
thank
hoy.
Michael for his presence today. And
Gracias a
thank you all
todos.
for being here.
Sí.
Thank you
Gracias
all,
a
and I
todos
would like to
y
meet
espero
you in
verlos
person
en persona
sometime.
también un día.
Bye.
Hasta luego.
Bienvenido entonces.
Have a
Muy
nice
lindo, buen fin de
weekend.
semana.
Thank you.
Gracias a ustedes.
It was spectacular.
Ya, Michael, muchas gracias.
Muchas gracias.
Thank you, Dr. Irwin. Excellent.
Excelente.
Una pregunta para finalizar, sería bueno
It would be
recordarles
good to
cómo
remind you
pasar la
that the conference will be in YouTube. Perfect. Thank you.
Perfecto, gracias, John Jairo.
Thank you.
Gracias por todo,
Congratulations.
felicitaciones.
Thank you, Imperia.
Imperia.
Hasta
Thank you.
Muchas gracias por su
Congratulations.
respeto.
I would have wanted to ask a final question, but we didn't have time for next time. Thank you. Thank you all.
Gracias a todos.
Thank
Muchas
you.
gracias a todos. Un
Have a
feliz
nice
día.
day.
Igualmente.
Thank you.
Gracias.